Thank you for this kind introduction, Raf. And I want to welcome everybody here to the GIEQs Symposium. So I was asked to give you a rapid tour of the important movement disorders of the upper GI tract and their diagnosis. I will be speaking about diagnosis and pathophysiology. I won't be touching too much the treatment. That is for my both colleagues that will follow. I have no disclosures. When we look at motility disorders of the upper GI tract, we can divide them depending on the anatomical level the problem is occurring. You have, of course, the oropharynx, the esophagus, stomach, and also the elusive sphincter of Oddi. Oropharyngeal movement disorders can have a lot of origins, like a muscular origin, a neurogenic origin, like, for example, in myasthenia gravis. But I will be touching the Zenker's diverticulum. Why? Because it is suspected to have a functional origin with a structural result. The underlying functional problem is sometimes called in literature cricopharyngeal achalasia, or spasm. And it causes secondary, a kind of diverticulum, which is a pulsion diverticulum, a false diverticulum, so with no muscular layer. And it's always located in the hypopharynx, so not in the esophagus. And the pathophysiology is actually not fully understood, but it is suspected there is an abnormal structure and motility of the cricopharyngeus muscle with abnormal pressures during swallowing in that region, and also an impaired compliance of the cricopharyngeus muscle. Symptoms can be dysphagia, halitosis, regurgitation, aspiration, and cough, sometimes even mostly in smaller diverticula with eperistalsis. The diagnosis is mostly made based on suspected on clinical symptoms, of course. Scoring systems can be used, like the Ecker's score, which is used for treatment and evaluating success of treatment for achalasia. We can see in this score that the cardinal symptoms of esophageal movement disorders are, in a lot of cases, dysphagia, also retrosternal pain, regurgitation, and in sometimes severe weight loss can be a problem. Sometimes patients complain also of acid burning. The second step in diagnosis with a patient complaining of dysphagia is, of course, an endoscopy. At the left side picture, maybe we can suspect something. When we see a tight sphincter and we feel some resistance passing it, we could suspect a problem of motility of the lower esophageal sphincter. Of course, on the right-hand side, we see a more clear image of a typical achalasia, and certainly when we do not see anything downstream that is blocking it like a tumor, this picture shows stasis, a firm dilatation, and we will feel mostly some resistance passing the lower esophageal sphincter. Then another diagnostic motility is the esophagogram, where a patient swallows some barium and a radiograph is being taken. It will teach us something about the motility, about EGJ relaxation, and about the absence or presence of stasis. The picture shown is a typical pathognomonical picture about a type 1 achalasia with stasis of contrast and food remnants in the esophagus with a marked dilatation. We need to be careful because a normal endoscopy and or radiography does not mean there is no motility disorder going on. For example, here when we look at achalasia and the three types, we see that in most circumstances for a type 1 achalasia, we see something on the upper endoscopy or on the esophagogram. But looking at the type 2 and type 3, certainly the type 3, in a lot of cases we really do not see big things. So that's why we need the next investigation, and it's the gold standard for esophageal movement disorder and the diagnosis is the high-resolution esophageal manometry. A catheter with pressure sensors is being introduced through the nose of the patient, through the upper sphincter, the esophagus, the lower sphincter, and the tip is in the stomach. And pressures are being measured when the patient, for example, swallows 10 times liquid and or semi-solid and solids, depending on the protocol. Indications for a manometry of the esophagus are evaluation of course, esophageal symptoms, where there is no clear obstruction problem on endoscopy, preoperative fundoplication, dysphagia, post-fundoplication or post-achalasia treatment, evaluation of motility disorders in systemic disease, like in systemic sclerosis, determining the position of the lower esophageal sphincter for pH monitoring, and in very specific cases, determining the myotomy length, like in jackhammer or type 3 achalasia.
Success rates in open trials are up to 90%. What does it do compared to Heller myotomy? This is a randomized controlled trial showing that it is as good as the myotomy, because that was the purpose of the study. So you see here that after 2 years, the clinical success is identical, around 80% after POEM or after Heller myotomy. A difference was for the advent of reflux symptoms. So there's a clear, significant higher number of reflux symptoms, PPIUs and esophagitis in the POEM group, clearly less in the Heller group. But which was strange is that the objective measures, such as the pH metry results, they were in fact identical between the two procedures. So in conclusion, what is evidence-based is that repeated pneumatic dilation offers similar success rates as a laparoscopic myotomy, and I suppose we can also say as endoscopic myotomy. It is the best treatment myotomy for a type 3, but reflux is more frequent following POEM. And that, of course, may be a concern in the future. We have to take this into account. It warrants our attention for the future. So when I'm coming now back to my patients, so I already told them about the medication, I told them about the Botox. What do I tell them about pneumatic dilation? I tell them, well, immediate success if we dilate 1 or 2 times, 30, 35 diameter, you have 80% success or maybe 90 of feeling very well. But the duration is 3 years, and we know if we admit redilations, it goes up to 85% at 10 years. But of course, every dilation has the risk of a perforation. Now, the risk of perforation is 5%, but when I talk to the patient, I tell them first, you have a risk of 5%. But of course, I also say that means that you have a risk of not being perforated of 95%. I think that the surgeon or the POEMist or the POEM endoscopist will say, yeah, you have a risk of 5% perforation. Well, I say you have a risk of 95% of not being perforated. But of course, pneumatic dilatation has multiple procedures, of course, in time. But Heller myotomy, to be complete, I tell to the patients that this exists, but of course I'm talking about operation, so they already are a little bit in fear. And of course now by having POEM, we know that this is not sexy anymore. So POEM, what do we know at this moment? I tell them, well, it's a new technique, it's an elegant technique, it's endoscopically, you don't have any scars, etc. The side effects are in fact very low. The only problem is reflux, 30% chance. But of course, if you have reflux, in fact, there's no problem. You can take a pill for that. We have very good medication for reflux disease. But of course, we will have to know in the future how this will evaluate.